Chris Rapoff of QME Continuing Education, and welcome to this week's presentation. Now, today I'd like to discuss a rather uncommon neurological disorder that's caused by the compression or an irritation of the superficial radial nerve. This is known as Wartenberg syndrome or chiralgia paresthetica. Today I'm going to provide some clinical insights and clinical characteristics that are necessary to have a firm grasp of before finalizing a diagnosis of Wartenberg syndrome in an examinee. So let's get started. First, these are the following sources that I reference when producing this presentation of Wartenberg syndrome. I encourage you to explore these references if you'd like a more in-depth understanding of our discussion today. Wartenberg syndrome is named after Dr. Robert Wartenberg, a neurologist who first described the condition in 1932. He observed isolated neuropathy of the superficial radial nerve and noted its similarity to neuralgia paresthetica, which you may recall that's a condition involving the lateral cutaneous nerve of the thigh. Dr. Wartenberg proposed the name chiralgia paresthetica to reflect the resemblance of neuralgia paresthetica. However, the syndrome has since been referred to by his name in recognition to his contributions to neurology. The Wartenberg syndrome is just a compressive neuropathy that affects the superficial radial nerve. And the superficial radial nerve is purely a sensory nerve that provides sensation to the dorsal radial aspect of the hand. Now, that makes it vulnerable to compression as it transitions to a subcutaneous position near the wrist. Common causes of this condition include repetitive wrist movements, external pressure from tight wristbands or watches, or potentially trauma. Now, as we discuss the anatomy, we do have a couple key points here to talk about. And first of all, the superficial radial nerve, as I mentioned, is purely a sensory branch of the radial nerve. It emerges between the brachioradialis and the extensor carpi radialis longus tendons. It becomes subcutaneous approximately 9 centimeters proximal to the radial styloid. Now, the nerve's superficial location there makes it very vulnerable to compression issues. So, potential problems develop when the superficial radial nerve is affected as it's compressed by possibly fascial bands or a scissoring action of the tendons during wrist pronation. This condition can become associated with repetitive wrist movements, for example, commonly seen in cumulative trauma injuries involving the upper extremities. You may be asked to examine these as part of a QME evaluation. The superficial radial nerve also is compressed at specific anatomical points, often due to the repetitive wrist movements or the external pressure leading to sensory disturbances. Clinically, the symptoms can include pain, paresthesia, and numbness over the dorsal radial hand. These symptoms can also worsen with wrist flexion and ulnar deviation. Now, physical examination of the hand reveals a positive Tunnel sign over the superficial radial nerve, with the symptoms being exacerbated by wrist movements. And as I previously mentioned, the symptoms are sensory in nature, as the superficial radial nerve is purely a sensory nerve. So there will be no positive motor symptoms as you examine for this syndrome. As you see the red arrow to the right, this is where you would perform a Tunnel's test or a Tunnel's sign for this condition. Now, diagnosing Wartenberg syndrome is primarily clinically based on a history and a physical examination. It can be supported by imaging, such as x-rays that can rule out fractures, and or an ultrasound or an MRI to visualize the actual superficial radial nerve itself. Differential diagnoses can be a little tricky here, and it can include de Quervain's tenosynovitis, intersection syndrome, which I'll discuss in a future presentation, and lateral antebrachial cutaneous nerve neuritis. So differentiating the Wartenberg syndrome from similar conditions is essential for effective treatment. There are some similarities between Wartenberg syndrome and de Quervain's tenosynovitis, so I thought I would discuss those here. First of all, the structures involved. Well, Wartenberg syndrome does involve the superficial radial nerve. However, de Quervain's tendinosynovitis involves the tendons and not the nerve itself. The symptoms include in a Wartenberg syndrome are caused by the sensory disturbances, numbness, tingling, the paresthesias, whereas de Quervain's tendinosynovitis is primarily causing pain and swelling of the tendons themselves. In diagnostic testing, as I had mentioned, Tenel-Sign is used for Wartenberg syndrome, while Finkelstein's test is specific for de Quervain's tendinosynovitis. Moving on to treatment, non-operative treatments will respond well to conservative treatments such as rest, activity modifications, NSAIDs, wrist splints, corticosteroid injections for the persistent symptoms. Operatively, surgical decompression of the superficial radial nerve is pretty much reserved just for the refractory or the persistent cases. As we discuss prognosis, it's very encouraging because with timely appropriate management, the prognosis for Wartenberg syndrome is excellent and allowing the patients to return to normal activities. And an early diagnosis and intervention is really, though, essential for Wartenberg syndrome to prevent the chronic symptoms that could linger for years. So, to summarize this condition, we've learned that Wartenberg syndrome is a rare sensory neuropathy caused by compression or an irritation of the superficial radial nerve. While it primarily results in pain, numbness, and tingling over the dorsal radial aspect of the hand, it does not affect any motor function, making it a distinct among nerve disorders. Diagnosis relies on the clinical assessment and it's supported by history and physical exams. There is some imaging reserved for complex cases, as I mentioned. Management is generally conservative, emphasizing on rest, activity modification, wrist splints, anti-inflammatory treatments, though surgery may be necessary for the persistent or the severe symptoms. With early recognition and intervention, the prognosis is excellent, enabling the patients to return to their normal activities, as we touched on today. Understanding the anatomy and physiology and the treatment approaches is essential for this effective treatment and the symptom resolution in this pretty manageable condition overall. Well, doctors, I'm Dr. Chris Rapoff, and I wanted to thank you again for taking the time to join me in this presentation. I hope you enjoyed it, and I look forward to sharing other interesting subjects as they relate to the workers' compensation system in the state of California. But until next time, thank you.